Numeracy is a really large part of health literacy. Many of us know lots of people who are very good at reading and comprehension, but math was not their friend. Math is not my friend. I love Excel right now because it'll do all of the formulas and all the adding, and I don't have to worry about it. So there are some people that math actually creates a huge anxiety. And sometimes it's flip-flops, do you know what I mean? Some people are really good at math, but they're not really good at doing the reading comprehension. So you throw in some of those old school math problems that we used to have to do. The train is leaving the station at 12:05, heading, those type of things, is that it combines all of those skills into it. And so health literacy, you need to think about it as one of those math problems where it's all of those lovely pieces that you got to fill out and figure out all the particulars on it. So we're going to talk a little bit today about how to make that a little easier and more comprehensible for your folks that you work with. We're going to define health numeracy, what that is. We're going to take a look at how it can affect the patients in your community. We're going to gain understanding on how people actually process data and learn some strategies for using numbers. But first, we have breaking news. There has been a recent outbreak of a really unusual disease. And they decided that this was such a great group here that they were going to ask us which program that we should use. So with this disease, program A will save 200 people will be saved, okay? If they do that program, they know that. If we do program B, there's a third of a chance that 600 people will be saved and a 2/3 chance that no one will be saved. So you have on your folders the corresponding color. A is the lime green and B is the blue. We are going to see how we should do this. I want you to go now with your lime green or blue for A or B and pick. Should we tell them to do program A or program B? Okay, all right. So it looks like we think that A would be the program that we should suggest to address this outbreak, right? Okay, so just in, they also provided us with 2 more programs. Now we have the choice of C, which 400 people will die if we choose this. And program D, there's a third of a chance that nobody will die and a 2/3 chance that 600 people will die. So I need you to pick C or D. So has everybody got theirs up there? Phew. All right. We're going to talk about the framing effect now. How we frame those program A and B, and then how we framed C and D was really interesting because 72% of people usually pick A over B. And then 78% choose D over C. Now this group looks a little more half and half, I think. What do you think about that?
The way it's worded.
Yeah, the way it's worded, and I think, no, I don't know. I don't want to get ahead of it.
I think it's because D and C had less facts. Like you had to make a judgment based on limited information versus A and B had more information.
Gotcha. Program A and C are identical, as are B and D. Yes?
And there's an and, it's not an or, so it's the entirety of, at least I noticed in D, but I didn't notice in B if it was an and between the 2 numerical values, if you really knew what that value was.
Okay, so let's go back to what you said first. Say that again.
Well, A and B were will live, and C and D were die. So
Okay. So you had to live and die. So we realized that people are actually risk, it's not necessarily a risk aversion as much as loss aversion. When we start to talk about people are going to die, that has a different frame for us. So then the next one, you had said about the...
I noticed in D, it was an and between the two numerical values, if you actually knew, was it a numerical value versus a percentage? But in B, I didn't notice, was that an and? If it's an or, then that's a different game, but when it's an and.
So the and the or and the way it was worded really kind of provided another challenge. How about looking at the two, 1A had just a number, and then B had, what did you have to do in B?
Just do some math and make a little pie in your head and take the slice off.
How many of you so like Joel just said, you actually had to kind of in your head figure it out, do the pie. How many of you actually did try to figure it out? Oh, good. There are some people that actually did. How many just went based on the fractions and were like that?
Well, I think it was because it said there was a chance,
Yeah.
you know, and the A was more affirmative. That was a sure thing. So
Yeah.
for life, that's a good thing.
Yeah, I
The
based
other
it
one
on,
was it was a chance that they'll live.
Yeah.
You know, so
Yes.
yeah, I based it on concrete percentages. Which one had more people living?
Right. So Derek did it based on how many were actually going to live, so he said, and did it on a percentage concrete. So we had a really nice mix. There were people who actually were trying to figure it out, others that might have been overwhelmed by the math, others who were like, I'm just going to save the most people, or I know for sure they're going to live versus it being a risk. Does this sound familiar at all? How do we relate this to the health field?
So you frame it in a positive or a negative to any individual facing any decision that they have to make about their care. And then how do you interpret or give them the hard numbers in the context that makes sense for them?
And it's survival rates. Lots of like diseases are presented, you have a 4% survival rate.
How much math was involved in doing that little exercise?
Two mathematical problems minimum.
So how many people found just the two even overwhelming? And it's okay, some people do. And like I said, you can't assume that everybody is going to have the same reaction to the same information. That math can be really exciting for some. And really having those firm 1/3 of this and then I know that this is that, that really gives me an empowered feel where I feel like I know what's going on. And the other person is like, oh, that is so overwhelming, I can't even understand what you just said. So, and then there's all those people in the middle. And just like we talked about in the other training, it's how do we communicate and how do we empower those and help educate and realize where they're at. And again, asking that simple question, how do you learn best? Is it visuals? Is it percentages? Do you want to read the studies? It's a good thing and a bad thing now that we have the internet. How many of you have been like, you think you have something, and you go right home and you start Googling medical MD, and you're like, oh, you start going down through all that. That's just a fun way to realize that everybody can look at the same thing and see different things. And it's also, if you have somebody that's facing a terminal illness or a real chronic thing, the way we frame it can make a huge difference. So just keep that in mind. So now we're looking at what health numeracy is. It's understanding it, but also being able to act upon it too. So how do we obtain it? How do we understand it? And it's putting the quantitative part to it now. So we've talked about the qualitative, but now when we start to look at, like you said, the dosages, that's a perfect example. Like having to understand exactly what the numbers are, especially would what chronic diseases do you think of has the most burden of numbers, do you think?
Like diabetes.
Diabetes, also asthma, being able to read the good and the bad and those ranges. CHF and Yep, so there's a lot actually, that when they start getting down to calculating, that there's a lot. But the diabetics, even if they're not on insulin, they need to be able to understand and act upon numbers of carbs and figuring out how they're eating. So there are a lot of times people will actually know where to look at the carbs on the list, and they know the sugar is there, but they don't know how to interpret it. Do you know what I mean? And they don't add it all up for the whole day. So you need to go beyond that they know where the number is. They need to know what those ranges are. So we'll look at, are there different ways that you can actually code it for them, talk to them about it, that isn't in numbers, because if you're like Pam and I, then you really want it not in the, like having to figure things out. You just want it, it says 400. That's all we want. So again, it comes back to our capacity to be able to communicate clearly and educate about the quantitative health information and empower them. So is it that we know there's a really cool app on the phone and you got a technologically sound person who's like, I love my iPhone. Oh, do I have an app for you? Do you know what I mean? Then you can get that and then they can do that. Do you have somebody that there's no way they're going to be on an iPad or an iPhone? Well, then that's not the way to look at educating them. Are they more of like every morning they do a crossword puzzle, so you could put it, you know, a sheet that they could do it next to that? There are different ways that you can look at how do you engage them. Where is health numeracy? Everywhere. It really is everywhere when you think about it. It is whether or not you're looking at the cancer statistics. It's again those ranges, figuring out weight. When your doctor says to you, you need to lose 10% of your weight. You know, you start doing that kind of a thing versus putting it in actual numbers. It's also tied to a shorter life expectancy, because if folks are having a difficult time managing those chronic diseases, the morbidity is just going to go up, the mortality. Higher incidence of ER visits. If your blood sugar level is out of control, if your CF, your congestive heart failure, CF started to do the the acronyms. If the congestive heart failure, you know, is out of control, all those things, you end up going to the hospital much more if you're not keeping a close tabs on it. Also, we talked about the gentleman who ended up in the emergency room because he took the wrong number of pills. Higher hospital recidivism. So people are going back to the hospital a lot more with the numeracy issues. Poor medication adherence, chronic disease management that we just talked about, that's really difficult for them, as well as the higher body mass index. Again, how do they do the math to make sure that they're within the frame of where they need to be. So we see the lower numeracy playing out in our health every day. Especially in the self-managed care, like we talked about in the last one, for Joy, is it Janice? Janice, we had discussed that individuals who had been diagnosed with diabetes 30 years ago actually were put in the hospital for 2 weeks and had 2 hours of training and education every day. Now with the self-managed care, people need to have even more numeracy skills. They need to be able to take their blood pressure, put it in the charts. They need to be looking at where they're falling in their ranges. Our health prevention, they also need to know the numbers of that. Patient choice, again, going back to looking at what choice did we make. Numeracy is definitely included in those decision-making situations, and lots of medical errors. And this is both on the patient side as well as the provider professional side. Again, making sure that folks are aware of all of the health-related issues. So again, this is just a quick example, and I'll let you read that, talking about the two areas for asthma care in which the numeracy provided a problem. So the top one, again, is a lot of the percentages. Do you know what I mean? And even though he went home with something that they feel he should be able to interpret it, he's still having a really difficult time. And the bottom example is she's too afraid to let her doctor know that she's having a really hard time plotting those numbers on a graph. Again, and we'll talk about the curse of knowledge, we sometimes forget that things that we use every day that are really easy for us are not really easy or common hand for everyone. So just like health literacy, that there's a large portion of folks that struggle, we have 30% of our population are at basic and 22% are at below basic. So over half of the population struggles with numeracy. And again, based on seeing some assessment scores of folks that are trying to start college, both right out of high school and coming back, it doesn't surprise me. The largest placement was always for remedial math. So again, taking a look at that, and only 13% are actually proficient. In general population, like I said, is 55% there. You'll see I put two different graphs to be able to show you. This is important too, because we're taking a look here. Some people are visual this way, and you notice that we put the largest number up on top. If you don't know, you can actually change the position of where your pie charts go, and they recommend that you always put the largest number up top if that's what you're trying to look at. And this was another one, is a bar chart. Instead of doing the vertical, if you put it horizontal, you have more room to put the words so that people can see that. So that's just another strategy as well of when you're taking a look at how do you display your charts. So math anxiety, again, is just like other anxieties, but a lot of people have that anxiety and it just takes over and they shut down. I shut down over my taxes. Like, I know it's a really easy form. My grandmother used to do them for me, and she'd be like, Karen, all you have to do is follow the directions. And I'm like, there's numbers. You know, and I just shut down. But I can fill out all other kinds of you know, forms and do things, but the taxes for some reason just freezes me. So that can diminish folks' ability, as well as we see a lot of folks who are older, like I said, they've been out of school a little longer, you know, trying to convert fractions into percentages and vice versa. The last time they'd done that has been a really long time, so they're at greater risk for lower numeracy. How patients learn. So we talked a little bit about this as well too, is this is another time to ask, how do you learn best? What type of information do you need to make a decision? And that'll gear towards what type of materials that you're going to pick. Data can be your friend or your foe. Now, this is my lovely dog, Lucy, and my lovely cat, Oatmeal, that neither of them are with us anymore, but this, I always entitled this picture Sleeping with the Enemy, because Oatmeal, his nickname was Slice and Dice. And so that dog was petrified that he had curled up next to her, and she laid there the whole time like, oh no. So just a funny way to think about your data. It can be a friend and it can be a foe, and knowing when you can use it both. And it's just as important to know when not to use it as it is to know how to use it. And we really need to know when you need to reduce the cognitive burden. When I started to rush you guys, like hurry up, they're gonna run out of time, did that like do anything with your decision making? It starts to like you just shut down and do whatever you need to. It's the same thing with the doctors. You go in and you know you've got like 7 minutes with them, and they're rushing and they're doing their thing. A patient or a person can feel really rushed and can have a lot of cognitive burden as all this information is coming at them. So we look at trying to reduce that burden. And you need to focus on the outcomes and the action versus the number. So that's really important, is not focus so much on the number or the percentage, but what is it that will it extend your life? Will it reduces the risk of heart attack versus 30% of people who take this experience. Curse of knowledge. I've talked about this in a bunch of ways. But once you learn something, it is so hard to believe somebody doesn't know something. I remember when VCRs came out. And I remember I was probably like 13 or so, and my grandparents couldn't figure out how to set the time. And I'm like, and you just go and you do it, because I always had the VCR. It had always been, kind of around. And it's the same thing is like now I have to have my 8-year-old cousin show me how to do something on my iPad that I didn't know that it did, but he's always at it and he can't believe I don't know that's how you do it. Same thing in our work, in our home life, we need to just make sure that we're not making assumptions that people know how to do that. I take for granted, because I had grandparents that were in the hospital a lot, so I knew a lot of the medical terms, but a lot of other people are not familiar with all those different types of doctors. So someone being referred to an oncologist may not have any meaning to them. Or, endocrinologist, what does that do? So that's just something to keep in mind. The other thing is to realize that there are two ways that people learn mostly. There are some people that are verbatim thinking. They're precise with the details and facts, and they're quantitative. Like, Derek, you kind of hit me as somebody that, you're very precise and you know that. But that is not the majority of how people think. But like, if you think about it, there are some people, I used to do this, or drive my friends nuts. So we'd talk about something that happened 15 years ago, and they'd be saying, and I said, oh yeah, I was wearing a red shirt, and you said this, and then we went over and we sat there, and it's just like, how do you even remember that? I just remember we sort of talked about it. I don't even know if it was in the winter, in the summer, all those things. So most people are gist-based thinkers, whereas they just want the bottom line of it. So in that conversation with my friend, she just remembers that we decided to go out and sing karaoke. Whereas I remember what all led up to it, that it was 7 o'clock at night, why we went and all those other things. Other people also, it's relational. They need to be able to categorize it, and there has to be something that's intuitive. There's a subjective based upon emotion, culture, education, experience, and our worldview. So as we hear something, if somebody is telling you that you have diabetes, that you're just thinking you might be basing it off of what you know about it. Do you know what I mean? Like, or I know my grandmother had sugar, and and not knowing exactly what that meant. So you have the gist of it, but you don't necessarily know all the details of it. So when we talk to people, it's important to know that if we get very precise, that complicates it, and that's that cognitive burden that they're going to have. So making sure that they have the gist of it, it bridges the information and the action. You can bring the data in then to reinforce what you just talked about in the gist. For example, so the doctor comes in and says, well, Mr. Fisher, your systolic blood pressure is 150 and your diastolic is 95, indicating primary hypertension. You'll cut your risk of heart disease by 50% if you can quit smoking. We could also get you on 25 milligrams of beta blockers once a day. What do you think about that? So that doesn't actually sound so far-fetched of what I've heard a doctor come in and say. That they're giving you the details. They're letting you know that what the blood pressure was, laying that right out there. And they're telling you that it's the primary indicator of hypertension. Then they also cut into that you're going to cut your risk of heart disease by 50% if you quit smoking. And then they want to talk about the medication. So someone might be like, so what did they say about 50 or the 25? And like, does it really matter at that point what the milligram is of the medication? Right there, you're trying to talk to them about that they are having high blood pressure, that they need to address the smoking, and that there is medication. So if we look at another way is looking at this and telling them that it's high. Pause. Let that sink in. If you quit smoking, you can cut your risk of heart disease in half. So you take out the 50. You don't need to have that in there. People know what half is. Pause. The pausing is really important because you're letting it sink in. And if any questions pop up, they're gonna ask you. And there are also medications that can help. So you've given this person actually the opportunity to kind of process. But even better is if you said the same thing, but when you paused, you went to the visual aid. So sort of like what Derek was saying about showing them what the range was, being able to show where their blood pressure should be. If you quit smoking, you can cut your risk of heart disease in half. Stop. Where are you in that? How do you feel about quitting smoking? If they're ready and they're afraid, you could actually do an action plan right then. Do you think you'd do better on the nicotine patch? How about gum? What about Wellbutrin? Do you know what I mean? You can actually talk about those action plan and make it. Because right then, that's what you're talking about. If you put it all up at top, and then at the end, you're like, oh, yeah, we got to address that smoking. You've lost that opportunity to kind of go through and have them process it, being able to see what is my problem, what do I need to do about it, and why is it important. So the same thing, kind of like, what is the problem, what can we do about it, and then at the end, being able to put in there a decision aid. And that's why is it important to me, the decision aid. Because at that point, they're going to be able to, if somebody's just gone in and they've had a mini stroke and they've been smoking all this time and they're pretty scared because the doctor says it's not a matter of when or if, it's a matter of when you have the next one, that decision aid is a good thing to be there in place. So using numbers with our patients. Again, they're everywhere. But there are a couple of different categories of the way people use their numbers, and you want to think about is basic category is reading numbers, counting, and telling time. So basically, if we're looking at medications and when they take that, those are the basic skills that somebody needs to be able to function at that. Computational, they need to be able to actually do the arithmetic, be able to calculate. Now the analytical is the ranges. So when we're talking to somebody about their blood pressure, can they figure out the ranges? If they're not analytical, then showing them that it's, the numbers and all this other stuff, that's not what's going to communicate to them. If you could just show them, red, green, good, bad, but however you need to do it, but knowing that the numbers are not necessarily going to be the impact for a person like that. Can they read tables and graphs? So if you're handing them information that shows them graphs, can they even make heads or tails out of it? How many research articles have you read that after you even look at the thing and you read it, you're not quite sure what exactly it's saying? I have, and I'm like, I need somebody to interpret what these trend lines are, and then when they start, you get into gap analysis and all these different things, it's really can be pretty challenging. And it's statistical. Again, being able to really read the complexities of it, taking the analytical side and comparing them and interpreting the risk statements. Most people are the basic and the computational. That's where we had 55% of the folks. The analytical, and then only, 13% of folks had all the way to the analytical. When should you use the numbers? And Why? The numbers really need to come out when we need to increase their knowledge. If it is a need that we need to do that, then that's when you should bring the numbers. But if it doesn't make any difference, if it's not going to change how they take their medicine, and it's their decision is made and they're following through it and adhering, then the numbers are not necessarily important to get all into, as far as the 35% of this, could, or if it's like, for example, if you're doing an informed consent and like only 1% of people have ever had like a adverse reaction, instead of using the actual number, you can say it's very rare in cases, blah, blah, blah. You don't have to actually use the number. They also say that whenever you're writing with numbers, even though like grammar tells us that the number, is it 1 through 10, you should spell it out. When you're doing this, numbers should be written out in their numerical, not spelled out. It's also good for decision making. So if somebody has a lot of information that they need and needs to make one medication over the other, then that time it does come in. There are some different decision making aids that can make that even easier just by asking questions, and then you flip over and you see what that medication is. So there are ways that you can still have the numbers in it, but not actually having the numbers be the primary. And sometimes you need it to persuade or motivate. So if you have somebody who has been smoking, they're not taking care of their blood pressure, and they're obese, you can really bring in and the numbers and say, these are the statistics, but I would do it at more of 1 out of every 10 person, not like 10%. But put it into like in human relational context. So it's not just a percentage, it's 1 of 10 people or 5 of 10 people. Using numbers, we should use it for order. Like you were saying, Pamela, earlier, start with the most important information first, too. So if it's how we order it, if it should be a lower number, that should be first. Also, if we're more concerned about a certain number versus the ones that are down at the bottom, start putting the most important up top. They should be in logical order otherwise, and also do the descending order in big equals bad, or the most important value. Okay. Less is more a lot of times. Unpack your complex concepts, do one idea at a time, keep the pieces logical and organized. That's really important to make sure that people are understanding the nature of it, and underscore the gist of each piece. So when you're using the numbers or putting it in, make sure that the gist part of it is in there as well as the verbatim, so that you're making sure that people are getting that. This is really important, is rounding the numbers and using the same denominator. Because it's really interesting. Again, remember math anxiety, and not everybody is great at math. If I start saying 1 in 10 and 1 in 5, or 1 in 10 and 2 in 10, some people actually think 1 in 5 is actually a better chance than the 2 in 10. Do you know what I mean? Like, oh, it's less risk because it's only 1 in 5, whereas it's the same as 2 in 10. But if you start mixing those examples, and also if you start with 78%, don't switch then to 8 and 10 people. You should try to keep it consistent of how you're doing that. And do the math for the people. So if it actually, like we use the example of you need to take this every 4 hours, or 4 pills a day, actually do the math and say that's every 6 hours. And if you need to do a clock and actually pick the numbers on it, then do that. But actually do the math. If it's you're giving a diabetic ratio of what they should calculate their glucose according to what their reading was, actually give them examples. Medicine cups and syringes. Actually mark it on the cup. So if you're sending home a parent or somebody with the liquid, or you know that they're going to pick it up at the pharmacy, actually have the cups on hand and mark it for them of what the 2 tablespoons look like, or whatever the measurement, cc's or whatever, because that is really complicated for some people of looking at that. And if we want to reduce medical or medication errors, that's one way we can do it. The same way with a syringe. Also, with syringes, knowing that that little stopper can be confusing to people of where actually that goes. Is it on the number, behind the number? So how do you actually do that? So if you actually took the marker and then talked to them and said, hey, this needs to be there. Remember, those people with the hands-on and the tactile stuff are going to have a much better time of going home, and they're going to be more likely to be successful in implementing that. And the pill cards. This is a part of the Agency for Healthcare Research and Quality. And they've done a lot. They have actually a toolbox, toolkit that they have on their webpage for health literacy. And this is one of the tools that they have. But they have lots of PDFs. They have a lot of PowerPoints and a lot of suggestions. If you haven't gone to this webpage before, I would highly suggest that you do. But as you see, they have a template. And really all it is a Word document that has a table, and they've picked a couple icons, and they have the typical medications that they use. So you can customize this to the folks that you work with. So don't feel like you have to go use the template that's there, but if you're using the same medications all the time, or you're using the same words or the same routines, you can make this really fit your population. But you want to be able to actually have a visual of what the medicine is. So, you know, life is really easy now with smartphones. You can take a picture of the actual pill and upload it, or you can go to the web page and actually do that. You need to make sure that if you're taking a picture, or if you found it on the web page, do you know what I mean, and said, oh, this is what it looks like, make sure that that's actually the manufacturer and what they're taking, because it can look different between the generic and all of that. Next to that is important information in really simple terms. So take 1 pill at night. It's for cholesterol. So again, this is in their words, not yours. So even though most people cringe when people say, I have sugar, instead of saying you have diabetes, if that's what they take the medicine for, is for their sugar, then you write for sugar, because that's what they're going to remember. Incorporating the information into the pill card, you can actually look at, if they take 2 pills, you can actually put that out. Or you can take a look at using the bedtime picture, the morning. Basically, again, finding a graphic that's going to make sense to them. And I would say go ahead and try to do this ahead of time so that you have something. But hopefully you can print this out for each one of your folks. Or maybe you can print it out and send it to them. But this would be a nice way. I think discharge planning, this would go a long way. I had heard in Chemung County that they're doing an effort, I think at Arnett, with Gerald's, beds to beds or beds to med. And something like that, but really what they're doing is a discharge. Here we go. Gerald is actually working with them of getting 7 days of whatever their medication is that they need packaged, that they will actually leave the hospital with that before they go. To me, that's amazing, and I think that's the right direction that we need to go, is because there's so much disconnect between the time you leave the hospital, leave the ER, leave the doctors, and then when you go to the pharmacy and get that. So whatever ways that you can implement, it doesn't have to be this way, but think of clever ways that you can actually assist the people that you work with. It's all about, again, finding what's going to work with them. When I was working with folks, the HIV and AIDS, and it was back in the late 90s when the antiretrovirals had just come out, and that's when they were taking like 42 pills a day. And that's when, if you missed one dose, you were going to become resistant. It was, this pill couldn't be with food, this one had to be with fat soluble, this one. So these folks were like all over the map. And so, you know, trying to find ways of like, so what time do you get up in the morning? Oh, well, I sleep in. Well, do you at least get up to go to the bathroom? Yeah, I do. Then set that pill bottle right there, or put it by your toothbrush, or whatever the morning daily thing was. But what our job at that time was trying to find ways to help them be consistent with taking their medications, and also simplifying it. I mean, think about, we didn't talk about this much in the other one, but it kind of comes in. Take this with food. What does that mean? Does that mean a cracker did it? You know, I ate a cracker and I'm good and I can go? Without food. Okay, so I didn't have anything, I took it without food, and then 15 minutes later I ate my lunch. You know, does that count? People don't understand those things. So we have to make sure that that is a part of what we're talking about when they take it. So when you're doing a pill card, it's about also making sure that they understand it. Remember how I said I fail every time at taking something 4 times a day? This would be a great tool to either work that out with me how I was going to do it if it was the only one, or get out of me that, oh, I really do not do a good job with that. They have this thing that's available where you can get the common pill shapes. Then, like I said, you can pick out what are the common icons. Medline Plus is a really great web page. And that is one that you can recommend to your folks that you work with, knowing that it has been evaluated and is actually approved by the National Institute of Health and some other organizations, that it has reliable information. And the great thing is that they can look up the pills and see them and read about the side effects if they have that capability. I remember my grandparents, they used to carry around like a pill book, because every time that they would get prescribed something, they'd want to look it up to see what it is. Well, the nice thing is that we do have the ability not to have to carry around a big pill book, but they can actually look some of the information up. But whatever's going to make it easy for you to create this, that would be great. And then this would be what it would look like for an individual person. So any information in the top would go that would be helpful. So say their neighbor is really good at helping them understand their glucose or whatever they have to. Then put that number for the neighbor or how they get them on there so that it's right there when they look at it. Put the date that it was created so that if somebody else looks at it, you kind of have an idea of when it was put together. And then you're going to put in the information here about what it's for, and then actually fill in with the pills. So if here we're seeing that they need to take that medication, you're actually going to put the 2 of them with the morning and with the evening so that they know what to do. So if there are any type of aids, or there are services a lot of times that you can connect people to that can help and sit down with. So that's another thing to know, is what community resources do you have that if you don't have time in your setting to do that, do you know how to make sure that you're connecting the dots? But also, if you're in a spot where you're seeing like, oh, we've discharged them and we don't know what's going from there, how do we make sure or have those community conversations that it's looping back around, that we're checking with each other? And I think that's really important, to make sure that we're having those conversations, that if I make a referral for you to go to the podiatrist, did I call and make sure that you were there, or vice versa, and then call and say, I see that you didn't make it. I know how outrageous that sounds to some people, like, oh, there's no way I have time to do that. But that is something that needs to be brought up, and there are care managers in there who are overwhelmed as well. But trying to look at that of how do you connect the dots, because we're all working really hard, and if we could just bring it together and be more collaborative, I think we'd be a lot more successful with our outcomes. So visual aids really reinforce the issue. How many people have seen Choose My Plate? So that is the new food pyramid. They went away from the pyramid, and now this is my plate. And so this really helps some people be able to figure it out without having to know numbers, without having to know number of servings, percentages. They can just look at that. So for your visual learners, like I said, ask them how they learn. If they're visual, then something like this works. When might this be an issue? Cultural competence. Not everybody, not every family eats with their food very separated. Like, there's not the chicken and the rice and the broccoli with a slice of apple. They're making a stew. And so when it goes on the plate, it's just all one on that thing. So how do you work with them to do this? So you need to remember that if you're doing something visual, remember the respect model. It would not be disrespectful to say, does this look like, your plate? Or how could we make this look like your plate? Those type of things. Also, be really careful of charts. Everybody thinks that this makes things so much easier, but that chart right there, it's like, what are they saying? Kind of a thing. So make sure that you use it sparingly, and make sure that you know that it's understandable. We use numbers when it is a narrative support. So again, that we can use the context and the reframing. We can link abstract to the concrete. And again, like I said, humanizing the numbers. If you can walk away with something today, that's a big one, is humanizing those numbers. And like we said, the cultural differences. Not only was the plate, but I didn't realize that this sign in Europe is like giving the middle finger here. And so I went to visit friends in there. Little one saw a picture of my cousin's kids doing this, and they're like, oh! So that was bad. But even like okay can be offensive in some other cultures. It does not mean okay. Red is actually, in some, can be really, we say it's stop, but it might have different meanings in a different culture. And also metric and the standard system. So making sure in the meanings and the connotations that we make sure that there's an understanding of the numbers there. In the plain language, it just keeps coming back to using plain language, avoiding the jargon, and background information on need-to-know basis. So if the numbers aren't pertinent, then don't throw them in there. If it's pertinent for the decision making, then they're good. The teach back method and the open-ended, you can use numbers, especially like if they're needing to calculate it. So actually saying, can you show me how you would calculate how much medication you should take? Can you show me, can you tell me what times of days you would take this medicine? Those type of things. And again, it's not about testing their ability. Make sure that they never feel like you're quizzing them. Make sure that it's more about you're quizzing yourself of whether or not you did a ample job of doing that. And avoid do you understand? And yes and no questions. It goes back to the open-ended questioning. And it's about finding that time to do that and being mindful about it. So again, when you visualize it, taking a look at the different ways in which you can put that out onto a graph, and looking at do they need is it a visual? This one has a visual and numbers, so they can kind of see that it's a major, but they can also, if they wanted to see the actual number, can look at that. True or false? Images like infographics are easier to understand than a paragraph of plain text because pictures don't require literacy skills. How many say true? How many say false? It's false. So it depends on how you arrange it and how you make it look. And again, like I said, the infographics, if you travel to another country and they're not the same standardized pictures, symbols, then it can be really challenging. So reading tables, this is a whole nother skill in itself. I would say stay away from tables if you can, because again, knowing how to read the rows and the columns and scanning up and down and repeatedly, there's a lot of room for making errors and mistakes. So remember how we said that half of the people recall the information incorrectly? This is an opportunity where you can recall it incorrectly because you read it wrong. And try to only have, when you're writing things up or you're printing things out, one message per graph. Fewer categories, downplay the noise. Now, the thing is, this is really challenging for marketing people, because marketing have gone to, and they've like, oh, look what we can do with these pictures, and we can make it look like this, and we can bring that. That makes it really challenging. Make it a lot of white background, avoid the pretty pictures and the embellishments, and simple, simple, simple. Now, it's going to make you cringe as a designer because it looks really boring, but if you want comprehension, that's your friend. Clarify, make sure it's audience appropriate. The order, make sure it's able to stand alone. So if you put actually something on there, if you can't understand it by just looking at it, then you either need to add to it or it needs to come out. And highlight or circle what you're trying to illustrate. Text. It should always be right justified numbers in the table. They suggest 10 to 14 point font, no frills, clear and concise, and the title should be who, what, and when. Color can be sometimes overwhelming and distracting. So it's really important to make sure that it has adequate contrast. Also, if you have someone who's colorblind, it could be really difficult to read. Printer friendly is really important because a lot of us don't have, as you saw, I printed some stuff out, I don't have a color printer. So does it translate, is it all one color then, kind of a thing. And looking for your action colors. Choosing a display type, remember the why. Why are you trying to do it? And also underscore the gist that you're trying to. So if you're just trying to get across that they need to lose weight, then that should be the gist of it, not going into all kinds of complicated statistics and those type of things. And use it as a supplement, not as a standalone. The pie and the donut charts, they're really good for highlighting smallest and largest, kind of like contrasting. They say not to do more than 6 slices because that can be really confusing. And like I said before, the 12 o'clock rotation, and use short labels in the legend. I wish I could take credit for this, but this is a Minnesota Health Literacy's PowerPoint, and I don't know if Rick Astley would never give you up, let you down, run around and desert you. Sorry, I just thought that was kind of funny. Again, you want to make sure that it makes sense and it isn't just adding to the confusion. Horizontal allows for your longer labels. The vertical is good for a rise and fall. So if you really want to show a drastic difference, they're great that way. 6 bars or fewer as well. They say don't overlay or stack bars. That can be really challenging to understand. Line graphs, don't do them. Just go past them. Icons, they can be pretty good when you want to show the absolute risk. Again, like that's a good humanizing way to kind of take a look at that. There's a generator, and that's on this slides that I'll send to you where you can actually go to the web page that you can generate those. Don't use too many colors. Make sure that it's spaced out. That is one of, like I said, the marketing folks love to get into all those pictures, but it's really hard to even tell what it's doing. That is a hard one. Again, that's the stacked, so that's difficult. And then that one, is it really giving you the information that you needed? You need to look and see what's best. That one is a good example of where you talked about starting with the good and going down. So it starts with the descending, and it's that the canola oil is the best, and it goes down, and they can actually kind of see what is going on, as well as the hearts make it. Those are good choices. You have the arrows like Pam had mentioned. So we're going to end on the risk communication, and I just want to talk a little bit about, and when I send you this, you're going to have all of these slides, but we haven't gone through all of them. But the risk communication is really important. This is where we start getting into really needing to know how to frame things. Remember back to that first exercise that we did. The same numbers, the same way we presented the information, or the different way we presented information changed people's views of what they selected. And that's going to happen when people are looking at their risk. Remember, we said we didn't want to lose anybody. So if we start talking about, this many people die, that's a lot different than this many people live. Do you know what I mean? So how do you frame that? Keep the denominators constant. Provide both the positive and the negative frame so that they can understand that. Also, keep your time frames consistent. If you talk about 6 weeks and then you switch to 14 months, or you know what I mean, like it needs to be within the same weeks or months or days, those type of things. This is what I really want to hone in before we go today, is about absolute or relative risk. This is really interesting to me because a relative risk, if we were talking to somebody, we say this treatment will reduce your symptoms, but it doubles your risk of cancer. How many of you would choose to take that medication by a show of hands?
Depends on the symptoms.
So the absolute way of saying it, this would make a big difference to me. With this treatment, your risk of cancer will go from 1% to 2%. So again, they're exactly the same. It does double the risk, but that makes me afraid. I'm like, oh, it doubles the risk of cancer. Versus, 1% to 2%, I can handle that risk. So knowing the difference between absolute and relative and making sure that, remember the curse of knowledge? We work in these numbers, or you work in that knowledge every day, and so it's really familiar and you understand it. You need to take a step back and make sure, is it familiar, is it understandable to the folks that we're relaying it to? I think about the spend downs and the donuts and all the Medicare stuff and things like that. Even those type of things, I mean, do people really understand what we're saying, even if we've been repeating it on a regular basis? If you want to do this with people when you go back, when I send you the information, there will be scenarios. So if you wanted to look at it, practice the teach back, or to how would we say this differently, you could actually do like a mini case study at one of your staff meetings. So just say, let's do this really quick. This is what the diagnosis would have been, this is what we would have told them, how could we have done it differently? And just go back down through it that way. So implement it, and also I challenge each of you to be a health literacy champion whenever possible. Speak up. It's kind of like, We always say, if you hear something, make sure you stand up and say for it. So if you're hearing an opportunity to slip in health literacy or training or advocate for health literacy for your organization, please do, because it starts with each of us.